We now call upon our esteemed chairpersons, Dr. B.V. Manjunath, Professor and HOD Department of Cardiology, AJ Hospital and Research Center, Dr. Sudhindra Rao, Professor and HOD of Medicine, Kshema, with special interest in metabolic diseases, infections and multisystem diseases, Dr. Bisto Akara, Consultant Endocrinologist at Dr. Bisto's Diabetic and Endocrinology Center and Daya Hospital, Thrissur, to grace the stage and chair the session. As diabetes and cardiovascular disease often go hand in hand, the need for early heart failure screening is critical. We now invite Dr. Ameya Joshi to speak on screening for heart failure in diabetes mellitus. Let's welcome Dr. Ameya Joshi.
Good morning, and this is a very important session. As a cardiologist, I always look at the management of diabetes in perspective of the heart failure, which is a very important question. Nowadays, we try to treat the heart failure before the clinical set-in of the heart failure. So therefore, there are some indications for us to use and intervene before the clinical onset of heart failure. Let us hear from Dr. Ameya Joshi.
Thank you, sir, for the kind introduction and also gratitudes for setting the context so beautifully. The talk is actually going to streamline early screening and interventions for treatment of heart failure in type 2 diabetes. And also I express my gratitude to Dr. Ganesh sir for giving me this opportunity and having me here. We Mumbaikars are actually big devotees of Ganesha, and it is a privilege to see Ganesha welcoming everyone over here. What I would like to know from the audience is that when exactly do you screen for heart failure in diabetes? Suppose a person who comes with breathlessness in your emergency room, we all get an NT-proBNP for that patient? Yes. Now, if a person has came to your OPD and is quite asymptomatic, has came walking, and he wants to know that how is my heart? Will you screen for that patient? Anything? Any ECG, any blood test, anything will be done? How many of you will do? Can you have a show of hands? Okay. And then actually, if the person is not worried, he says, doctor, I am fine, the sugar is so and so. Will you screen for heart failure in that patient? Anybody will? Even without symptoms, you will be screening for heart failure in a patient in their OPD. I think very good. I am actually happy to see some hands rising. And I mean, sir is a cardiologist. His role comes later. All of us, physicians, diabetologists, endocrinologists, actually have to screen people with diabetes whom we see for heart failure. And that is what I will be speaking on. Maybe I would be sharing our experience of outpatient screening for heart failure in type 2 diabetes. Now, this is the reason you actually screen, because when a person with diabetes comes to see you, you are supposed to treat the person based on presence or absence of cardiac and renal complications. And how will you know whether the person has a heart failure or not? You will only come to know based on doing the test. Will you do an ECG to diagnose the heart failure? Will you do echo to diagnose heart failure in everyone? Okay, some hands. Will you do some blood test to diagnose heart failure in everyone? Okay, no hands. Anyways, I think screening is a reality, and that is what we need to do, because other than that, we cannot stratify the risk. And it is important to stratify the risk because in a person attending your OPD, even the ADA guidelines say that 22% may be harboring a heart failure. So straight they go on the right hand side of the glucose management table. And that is the need to identify the risk factors and the treatment. Now, let us go back and see what ADA recommended maybe 3 years ago. The ADA guideline actually did not talk about heart failure that time. The ADA guidelines said all people with type 2 diabetes should be screened with a ASCVD risk estimator. Come to Europe, they said that it is not applicable for our population. We never had any clear stand on that, and in almost all the narratives it is said, calculate ASCVD risk score. To tell you about it, ASCVD risk score underestimates the risk in lower socioeconomic groups. It does not consider family history of heart disease, and the modern risk factors like prolonged sitting, excess of mobile, ultra-processed foods are nowhere in the ASCVD risk score. Remember, humanity has evolved. The time when ASCVD risk score came was a different time, and now it's a totally different time. So then we decided that let us begin, because COVID gave a time to think, and we realized that a lot of our patients who actually have a normal ECG and at times even a 2D echo, which was reported as normal, I mean some diastolic dysfunction, but they used to land up in an emergency room, and they used to tell us that, doctor, I am following up, and why am I in the emergency room? You tested me, I tested, everything was told all right, and still I am here. So we thought, let us review our records. We looked at what ASCVD risk score was in people who got hospitalized and their matched controls. What we realized is that the scores were not different in the cases and controls. And more than that, the risk that we got was actually 14.5% at 10 years when we did ASCVD risk score. But we had 16% event rate over 6 years when we back tested the algorithm. So that translated into close to 25% risk at 10 years. So a gross underestimation of risk happened in the ASCVD risk score. So we tried to see which is that population which is missing in the ASCVD risk engine. And we realized that the family history of heart disease was a strong determinant of heart failure, and that was not addressed in the ASCVD risk score. But then, you know, heart failure in diabetes is much beyond that. 70% close to will have ischemic heart failure, but you will see 30% people who come to an emergency room, breathless, you will get a raised NT-proBNP, you get their coronary vascular evaluation, CAG is normal, non-obstructive CAD, or almost nothing. Coronary calcium scoring is 0. So then to collate both of them, we looked at another risk score, that was watch DM risk score. And it's an evolving one, again, not tested in Indian population. However, we continue to wonder what is going wrong. And then we changed our question, you know. We asked what tests we do, and we come to know that in next 5 years my patient is not going to die or not going to have an event. And that took us to a research paper by Blaha in 2016 published, which looked at various markers. And then we chose 2, coronary calcium scoring and NT-proBNP. Now calcium scoring becomes ischemia specific. I'll allude to it, but not in detail, but I'll allude to biomarker. And in 2022, this paper by Dr. Radhika Pop-Busui came, which was actually both vetted by ADA and ACA, cardiologist and endocrinologist. And as Sir said, that told us journey of heart failure in diabetes, which begins on stage A, and diabetes is a risk factor. So any diabetic person is at risk of heart failure. And stage CD, where your symptoms come, and the echo is unequivocally showing something in a properly done setting. In between the two is a stage called as stage B of heart failure, where you will get subtle findings on echo. If a cardiologist does it, you will get a really good objective record. Echo is something that can be done anywhere and many people do it. So you may even actually not be able to see what exactly is there in the echo. So could it be done in a more objective manner? And then they realize that the biomarkers of heart failure which they are using in the emergency room, if used at a lower cutoff, give you a risk of heart failure. So they zeroed down on a marker called as NT-proBNP. And we will be discussing about our Indian data about NT-proBNP. So whenever a heart is under a stress, it slowly starts releasing BNP, and NT-proBNP is the N-terminal proBNP. NT-proBNP is preferred because of better sensitivity and predictive value, as well as it doesn't get interfered in a person on ARNI. The cutoff for NT-proBNP is 125. So in an emergency room, up to 400 you say is okay. But in an OPD patient, if you see a person walking, talking, NT-proBNP level more than 125, the person is at a high risk for heart failure in next 1 year. And if a person has done an NT-proBNP, so you found at 200, you did some changes, patient comes for follow-up, NT-proBNP has become 500. OPD setting, not yet hospitalized, you can immediately tell you need certain changes in treatment. Again, I will be coming to what exactly can be done. So serial monitoring of NT-proBNP also predicts heart failure hospitalization in a strong way. Now let me take you to this interesting study called as Pontiac. What they did is, they simply recruited 300 patients with type 2 diabetes who had a normal ECG and 2D echo. So ECG normal, 2D echo normal, exactly the population that we were talking about. And in one end, they were under close follow-up. And what was done? No SGLT2 inhibitors that time. Only adjustment of ARBs and beta blockers to optimize heart rate and blood pressure. And in another group was on a regular clinic follow-up. What they realized is that a simple close follow-up can eventually eliminate the risk of heart failure hospitalization in a significant manner. And so this NT-proBNP cutoff gained strength. This was one of the study collated by ADA as a landmark trials where they used a cutoff of NT-proBNP. In a non-diabetic, the cutoff is validated at 100. Now this is our own publication where after the 22 paper, we actually started screening for NT-proBNP in all our patients who agreed to get it done. So what we did was that NT-proBNP costed 3,500 that time. We did some bargaining with the lab. We told the kit manufacturer that we will be consuming more kits, got some discount, reduced the price to 1,500 for our patients to do. We labeled every patient whom we used to screen in OPD as diab NT-proBNP so that we could follow them up. And then we offered the test. Obviously, patient was paying out of pocket. So there was a little bias, maybe you can say. Maybe people who had family history agreed more to get themselves tested. But all people had normal ECG, no past heart disease, came for OPD evaluation. In an endocrine or physician OPD, we realized 32% of our people, so we screened total 1,050 people, and 32% of our this is a hypertensive subset, but in all population also after expanding, we got 32% positivity in 1,050 people for heart failure in our outpatient setting. On day one only we decided that this marker is costly, we can't do it for all. So let us try to identify who were vulnerable. So an aged person was more vulnerable. Anyone who had a longer duration of diabetes, the disease increased. I don't know how common it is in Mangalore, but tobacco chewing is very common in Mumbai and Gujarat side. And we realized that tobacco chewing is little more risky or almost equal to smoking in terms of risk of heart failure. Uncontrolled hypertension. Many times we see people ki BP is not coming under control. You do their NT-proBNP, you realize that it is high. You change the management perspective and you get a better result. A tachycardia in the OPD, more risk for heart failure. Dyslipidemias obviously are more at risk. CKD and family history. Remember, if your patient has a family history of heart failure, start screening 10 to 20 years early. You might get a higher screen positivity rate. Japanese were first to recommend it in 2021, Europeans were second, and ADA was third. In 2022, it came with a position paper. But in 2024, ADA guidelines clearly stated NT-proBNP for people above 50, and in 2025, the ADA guidelines tell you that all people with type 2 diabetes need to be screened by biomarkers. So they don't recommend ECG. Every year you do NT-proBNP. If it is above 125, make a cardiac referral, start the treatment separately, reclassify the patient and work on it. Now, one of the interesting question that many endocrinologists and diabetologists asked me, why are you doing anti-proBNP? 100% of my patients are on SGLT2 inhibitors. It's not true. I would swear and say that 40 to 50% people are, 100% penetration is not there. But then even if theoretically you say 100% of my patients are on SGLT2 inhibitor, I'll tell you, look at these people, you can actually realize that you are entering into another disease. It's not merely about SGLT2 inhibitors. SGLT2 inhibitors will reduce your anti-proBNP by 20 to 40%. There are so many things to do both for a cardiologist and endocrinologist to prevent a hospitalization. And we actually, because we got a lot of people who got screened positive, very difficult for a cardiologist to do so many cardiac evaluations. So then we did coronary calcium scorings for all. Then we analyzed that raised anti-proBNP with CAC means significant blockage chances are very high. But then lot of treatment changes a cardiologist can do, lot of treatment changes endocrinologist can do, including better metabolic control, not merely SGLT2 inhibitors. And this is a small checklist. So whenever if you want to ask what beyond SGLT2 inhibitor, remember these things. Optimum glycemic control, reducing weight, simply normalize the heart rate and control the BP, screen for thyroid, do a direct renin in all people where your blood pressure is not coming under control in more than 2 drugs, and you will see that mineralocorticoid receptor antagonists work very well in them. Simply correction of anemia can help you control. All of these measures that we realize, it's a group discussion that has led to this checklist from between medicine, endo and cardio department, and all of these measures will reduce your anti-proBNP by 10 to 15% at least. Now coming to 2D echo, because 2D echo is easily accessible to us, not as difficult as compared to Western population. But then if you want objective markers on 2D echo like a GLS score, you need an additional software for that. Look at the parameters of 2D echo that are described, and you will see that it is only possible if it is done with dedication. A 2D echo that is haphazardly done will more often than not come with a report of diastolic dysfunction, and you will find equal number of anti-proBNPs high and low in the same people with 2D echo. Now having said that, in last couple of minutes, let me take you through 3 real world scenarios. There was a 57-year-old gentleman who came to the emergency department. He was on metformin, sitagliptin, dapagliflozin. He said, doctor, there is a pain that is going in my left hand. Immediately our cardiologist came in the picture. He said, angiography is a must, patient is diabetic. Now that patient said, doctor, I have been screened in the OPD. That they did a test, and my blood test actually showed that I have very less risk of heart problem in next 1 year. So why do you want an angio? We said, okay, we'll redo the test. And we realized that the anti-proBNP was 20. So cardiologist also was relaxed, but he said, let us do something more. We asked the patient to do a coronary calcium scoring because patient was not willing for angio. Coronary calcium scoring was 0. Patient has simply cervical spondylosis. What was avoided? So that is the benefit of negative screening also. And unnecessary angio was avoided, and more importantly, empiric treatment with blood thinners, antiplatelets, so and so was avoided. Now, there was another gentleman who actually was due for knee joint replacement. The person was little overweight. His ECG 2D echo was normal. Since we were doing anti-proBNP, anesthetist recommended get an anti-proBNP done. The person's anti-proBNP was 440. The person never got breathless because the person never walked much. So automatically, because lack of effort, there were no symptoms of heart failure. We told the person to get a coronary calcium scoring, it was 980. The person actually had a triple vessel disease, and before undergoing a knee joint surgery, he underwent a CABG. So practically, if you have to give pre-operative fitness also, it's a very good test in every type 2 diabetic to reassure beyond simple 2D echo. And then there was another lady who came, and in our routine evaluation, we realized that she had a raised anti-proBNP. She said, doctor, I am 60 now. I don't want any more tests. I don't want to spend more money. Do whatever you can within your limits. We did a coronary calcium scoring. It actually showed that she had coronary calcification. She refused for CAG, but a timely best medical management that we gave, and even the ischemia trial confirmed that if you can treat before an onset of event, that is the time where best lifestyle modification helped and our patient can actually we could protect. So heart failure remains an under-recognized complication. It may be significantly prevalent even with a normal ECG and a 2D echo that is apparently normal. The risk increases with increasing age, longer duration in people who are smokers and having chronic kidney disease, uncontrolled hypertension, think of heart failure. 2/3 of it is ischemic, but 1/3 is actually not ischemic. And the blood test to screen for heart failure in type 2 diabetes in a stable OPD setting is NT-proBNP with a cutoff of more than 125. Thank you one and all for your patient listening.
Thank you, Dr. Joshi, for emphasizing the importance of proactive cardiac screening in diabetes care. Your clinical takeaways were truly valuable. DICE is now open for discussion.
Thank you, Dr. Joshi. It was a wonderful talk, and you have almost covered every aspect of the heart failure management in diabetic. So I like to add 2 points. One is that, yes, the role of NT-proBNP is very much established by ADA in 2025, and we are supposed to do in an OPD basis also. But in addition to that, the most important point is when we ask for an echocardiogram, simply doing an echo LV function is not good. We have to do what is called GLS, that is the global longitudinal strain. That is the one which picks up the LV function decrease early than the regular 2D echo. So this is what very important, but especially in diabetic, if they have additional risk factors, we should go for GLS rather than plain echo. The third thing is that we also should emphasize the fact of microalbuminuria and UACR in all the patients of diabetes, because early onset of microalbuminuria and UACR ratio will also help us to prevent the cardiac events, including the heart failure. So in our armamentarium of clinical OPD things, when we ask for, apart from HbA1c, and I think we should add NT-proBNP and GLS as well as microalbuminuria and UACR.
It's a very well taken point. I really appreciate your inputs because GLS is one thing that could be done, but then it needs a separate software. And as I said, echo is very much dependent on, even if I tell that, okay, this is the cardiologist I want a 2D echo from, or maybe go to our cardiology department, patients get from any diagnostic center where, I mean, don't want to put up anything, but sometimes you just get an echo which is, I mean, you might have seen more world than me, sir, but the second thing is the heart failure risks actually started with whether HbA1c is a predictor. It was, but not a specific one. Microalbuminuria was a better predictor, but NT-proBNP bettered them all. But thank you for highlighting those points.
How many of these heart failures are actually non-ischemic or myopathy related in your?
Yeah. So in our quest to know what caused heart failure, we also economized calcium scoring for our patients, and we did on a more broader scale. So anybody with raised NT-proBNP, we sent for CSC first because it would prevent even overloading of the cardiology department. And we realized that 2/3 of our patients had a CSC above 100. So 1/3 is actually non-ischemic. Yeah. Yeah, so what your official guidelines actually tell is stick to 125 till you get further validations for old age. So what it means is that in CKD patients and in old age patients, you are more likely to get false positive NT-proBNP, but the cutoff remains 125 as of now. I am sure there will be age specific, and some authorities actually claim 300 to 400 should be considered, but that's after 75 years of age, not at 60. So that is the thing.